of the feet, the bowing legs, and on the back, if any meningomyelocele, or look for the imperforate anus. Okay. In genital examination, genitalia should be clear. Either baby should be male or female. Sometimes you may be confused, and the appearance that might be an abnormal, you can label as ambiguous genitalia when you can't differentiate whether it is a male or female. So the checklist for newborn is important. So first, see the general appearance, whether it is a normal or abnormal. If you have any abnormality in the kid and newborn, you must highlight it. Okay, the color of the baby is also important. Okay, so in check for the muscle tone, whether baby the hypotonic posture is good or frog-like postures, whatever. If patient is the edematous cyanosis, sometime congenital heart disease, cyanotic heart disease can present earlier. Sometime there's a hypothermia can cause the peripheral cyanosis, and look at the nasal flaring for the sign of any respiratory distress along with intercostal recessions, and look at the babies standing with the meconium. Mostly the postpartum babies, okay, the postpartum babies having problem of meconium standing. Okay, so look at the umbilical cord, nail, skin. If they are stained with the meconium, you should label that this is a meconium stained baby. Then see the skin. Okay, whether baby is a paler looking or baby is pinkish. Hemoglobin is more in the babies and the color known as a plethora. Okay, if baby is jaundice, you can look for the jaundice, for any petechial rash or any ecchymosis on the body. So skin color, the texture, any rash, if you noted on the body of the baby, you must highlight it. Okay, and then check for the vasomotor instability, like the mottling, the telangiectasia, cutis marmorata, acrocyanosis, or harlequin color changes. Sometimes there is a clear demarcation of pink and other color on the bodies, so you can label this as a harlequin. Mottling is some sort of the vasomotor instability on the skins and the sign of any presumed sepsis, and you can easily pick that this is a mottling. So this is the certain color changes, and different various color changes occurs in the cutis marmorata. You can also label this is the finding. If patient have peripheral cyanosis due to the hypothermia, the vasoconstriction of the peripheries causing the cyanosis, you can label this as a vasomotor instability or vascular problems in the babies. You must highlight, you should mark on your notes on the checklist, whatever the finding which you are seeing in the baby. And look for the hemangioma. Certain hemangiomas are seen at the birth, like capillary hemangiomas, cavernous hemangioma, certain stains on the bodies like port wine or nevus flamus or nevus simplex. These are the spots on the bodies like Mongolian spots, birthmarks, the laningo hairs on the body. These are the hairs on the body presents at the birth. And sometimes you may find the abnormal tuft of the hair on the spine at the back, what might be a sign of the any spinal cord deformities. And look at the caseous material on the body when baby born, known as a vernix caseosa. And sometimes skin disorder can be present like ichthyosis, neonatal rashes, the erythema toxicum. These are the small rashes, and these are the non-toxic or benign. Sometimes little spots on the face, and that's known as a milia. So these are the findings you can be seen on the patients. And start, as I have told you early in my lecture, you should start the exam from the top to toe and front to back. Look at the shape of the skull, whether it is a normal shape or skull seems to be a smaller shape. Smaller shape skull known as a microcephaly. Large shape skull is known as a macrocephaly. So it is the appropriate size or microcephaly, macrocephaly. If you can't differentiate, you just measure the fronto-occipital circumferences, okay? And sometimes pelagocephaly means the occiput is a flat, and cranial synostosis. Synostosis means the early closure of the sutures of the skull bones, the craniotape, the fontanelle. Examination of the fontanelle is important, the anterior fontanelle and posterior fontanelle. So look at the shape of the skull. And note if any abnormality you have seen in the baby. And after the skull, you should look at the face and check the eyes, whether eyes seems to be the normal or small eyes known as macrophthalmia, large cornea type like megalocornea, if any congenital cataract present, coloboma, the absence of the part of the eyelids, okay, known as coloboma. Congenital and retinal hemorrhage may occur in the birth process. Leukocoria, it is a white reflexes. Okay, you can see any abnormality in the eyes and you should label that this is a problem with the baby. Look at the ear deformities. Any preauricular skin tag, any sinuses or absence of pinna, you should label that this is a problem in the ears. Look at the nose, the patency of the nose is important. And check the mouth, the oral cavity examination is important for any precocious dentation, any cleft lip, cleft palate, micrognathia, tongue tie, you can pick, you can examine for any abnormality seen in the mouth. Then check the neck, and the neck, the midline mosses, any goiter, any thyloglossal duct cyst, any moss in on the lateral sides, the brachial cleft, the cystic hygroma, the neck webbing, the sternocleidomastoid lesions like clavicle fractures, which may occur during the birth process, hemivertebra, the unilateral atlanto-occipital fusion that's known as a carpal field syndrome. Here the neck seems to be the short, or any congenital cervical vertebra fusion, if you can found there's a. So the thorough examination of the neck. After the examination of face and the skull, you should do the examination of the neck. Then see the chest. And if chest is a bilateral symmetric or asymmetry, look at the breasts, any additional nipples like known as supernumerary nipples, inverted nipples, widely spaced nipples. So any abnormality you see in the chest, you can highlight it. After the chest examination, you should do the examination of the abdomen. Tummy examination is important because of the umbilical cords. So the shape, look at the first shape, whether it is a distended, scaphoid shape, or any moss feel in the abdomen, any congenital moss or some problems, like look at the umbilical cords, umbilical hernia, omphalitis, omphalocele, any bleeding or discharge from the umbilicus. You do the thorough clinical inspection and examination of the abdomen of newborn. Genital examination is important in newborns. When you are first looking at the baby, do the thorough examination, because you are able to differentiate the gender, and you should tell the parents whether they have a male baby or female baby. But prior to telling, you have to do the clinical examination thoroughly. Look for in male babies, look for undescended testes, any scrotal swelling, any hernia, hydrocele, torions of the testes, the hypospadias, epispadias. And females, you have to look for the imperforate hymen, enlarged clitoris, and the back you should look for the imperforate anus. It's important. We usually do not miss this portion to do the examination of the anus. Okay, or any sinuses presence. So sometime we are unable to discriminate or differentiate the gender, genitalia are not so clear, then we label as ambiguous genitalia. It is an other entity in which your counseling is important to tell the counsel to guide the parents regarding the baby's investigation further follow-ups. Then lower extremities, the legs, thighs, and the foot examination is important. Look at the normal shape of the foot, whether foot are everted inside. Okay, so color foot is one of the common problems in the abnormality of the feet. And so the thorough examination of the foot is important. Feet is also important. Look at the metatarsus, calcaneo, valgus feet, talipes, rocker bottom feet. Sometimes foot are the flat. There is no arch in the feet, known as a pes planus. Congenital vertical talus, or sometimes you have dorsal collions or peroneal spastic flat foot, pes cavis, equino, cavis, calcino, cavis C. These are small bones in the feet. You can look at any deformity, mostly the club foot and the flat foot, the pes planus. These are the common problems in the babies. You can diagnose early, and you should take the expert opinion or some sort of the treatment, whether needs the any surgery or only the applying the plaster is important in this baby. So the early recognition of any foot problem, you can treat early, they have a better outcome. So look at the sole of the feet and look for the arch and flatness of the feet. These are the important. And look at the gap in between the great toe and other toes. If gap is wide, it occurs in certain syndromes like Down syndrome. The shape of the feet is also important. And in the extremities, look for the polydactyly. Okay, polydactyly means extra digits. Syndactyly, there are small fused toes or hemihypertrophy, in which the one side of the limb is enlarged than the other sides, and it occurs in certain syndromes. Look for any atrophy, overlapping of the fingers, the Simon crease in the hand. This is a single transverse crease in the palms, and it is a feature of the Down syndrome. Look for the rocker bottom feet. It also occurs in certain trisomies and other syndromes. Look for the club foot, any fracture or congenitally or any amputation. So extremities examination is also important for any abnormalities. This is a flat foot, no arch inside the foot. Then look at the toes, the curly toes, the congenital, digital, minimus, varus are overlapping of fifth toes, polydactyly, syndactyly, mallet toes, the phlegon contracture at the distal interphalangeal joint results from congenital shortening of flexure digitorum longus tendon and collar toes. So any deformity, you can just take or highlight it in the toe. And check for the leg, any bowing, femoral antevoyance, tibial torion, genu verum, and genu valgus. And genu verum is known as a knock knees. Both knees are joints, and genu valgum, the space in between these two knees increase, and there is a bowing, tibial bowing. So these abnormalities you can see in newborn and children, mostly the patients with rickets And if parents ignore their baby and they came with the late findings, you may found these problems in the children as well. And hip examination of the hip joint is important because if any congenital hip problems, we can early detect, we can early intervene, and the outcome results are the good if we detect early, and we will take certain steps for abnormalities, for any problems. Early intervention has better outcome. So congenital dislocations checked for gluteal fold asymmetry, leg length discrepancy, the Barlow's test, the autonomy maneuver. These are both are very important tests for the hip joint. Okay, for Barlow joint, Barlow test, Barlow maneuver should be. We are doing the Barlow maneuver for the dislocatable or weak joints. Okay, this is a provocative test for any hip joint which has a tendency to become dislocated. And autonomy is for the dislocatable. It means the already hip joint is dislocated. The head of femur is not inside the acetabulum. Okay, it is outside the acetabulum. So these are the two important tests for the hip joints. Look at the spines. Spine examination is important, and as I have told you, on the back sides, look at the spine examination. The most common problems is spina bifida or meningomyelocele. So look at the spine for wedge vertebrae, for hemivertebrae, for block vertebrae. Block vertebrae means the 2 to 3 joint vertebra are the fused. Scoliosis, kyphosis, spina bifida, spinal dysraphism, like I've told you, meningomyelocele, sacral hair tuft, and intermal sinus or meningomyelocele. Obviously, you can pick easily if this problem has patient have, but for this problem, you must do the examination of the back. It is important. Look at the shoulder joints, brachial plexus, birth palsy, any sphingal deformity, any congenital elevation of the scapula, shoulder dislocations. So if any problem you can notice, you can highlight it and do the examination of the elbow joint for radial longitudinal deficiencies like congenital hypoplasia or absence or radial aspect of forearm, wrist, and hand. Congenital contractures, any orthogyropsis multiplex congenita, there is a contracture of the multiple joints. You can see even in the mothers, and usually with oligohydramnios, these problems can occur. So after the checklist, our other topic is developmental dysplasia of the hip. So before going to discuss this, you have a checklist top to toe, front to back for the examination of the newborn. And developmental dysplasia of the hip involve the displacement of the femoral head from the acetabulum during the perinatal period, which disrupts the normal development of the hip joint. Developmental dysplasia of hip is estimated to occur in 1 to 1.5 per 1,000 live births, and it is more common in the female sex. Okay, so the female sex are more prone to develop DDH, being the firstborn child, breech positions. These all are associated with an increased prevalence of the DDH, and positive family history is also having a chance of up to 10% to develop the developmental dysplasia of the hip joint. It is mainly classified in two major groups. Typical one in neurologically normal infants. They have only isolated developmental dysplasia of the hip. and other is teratologic. In this condition, in which there is an underlying neuromuscular disorder, such as myelodysplasia, arthrogryposis multiplex congenita, or any syndrome complex. So underlying neuromuscular disorders, it is associated, and this is type known as the teratologic. Clinical manifestations. Early clinical manifestation of developmental dysplasia of the hip are identified during the examination of the newborn. I have told you earlier that we perform the two tests. One is a Barlow test and other is autonomy. The Barlow test is the most important maneuver in examining the newborn of the hip. So how we will perform? Look at the newborns and the Barlow test. We stabilize the hip with one hand, and hip should be the flex, and you can adduct the hip. Okay, so what will happen? The head of the femur will become slipped out of the acetabulum, and it causes a click sound. So if you will apply the pressure posteriorly in this direction, you will do the adduction, and there is a click sound. It means that this is a dislocatable hip. Okay, so the Barlow test is for the dislocatable hip. Okay. And other maneuver known as autonomy maneuver. This is a very important maneuver, and here already dislocated. The head of femurs is already outside from the acetabulum. Okay, and you can flex the hip, and you can abduct this one. Okay, so the head of femur comes inside to the acetabulum with the crunch-like sounds, and you can feel that this is a dislocated hip. So the autonomy maneuver is for dislocated hip, and Barlow maneuver for the dislocatable. So this is a two differentiate one. Here the hip joint is a weak, and this is a provocative test known as a Barlow maneuver. And autonomy is test performed for the dislocated hip. So these are the two tests. Your idea, you should be clear about these two. And if you will do the clinical examination and the late age of developmental dysplasia of hip, when child is 3 to 6 months, the Galeazzi sign is a classical identifying sign of the unilateral hip dislocation. Okay, there is no symmetry. One legs, there is no symmetry. Okay, so one leg is upwards and other is downwards. So discrepancy in both these two. Okay, and this is a Galeazzi signs. For dislocatable hip, the ultrasound is easily one of the tests you can perform of the ultrasound of joint, or you can do the radiology. So the other signs include increase in depth or asymmetry of the inguinal or thigh skin folds and dislocation of the hip. Trendelenburg test, it is a test performed in the older children. Drop of the normal hip when child is standing up on both feet, the elevated unaffected limb, and bear weight on the affected side due to the weakness of the hip abductor muscles. And the gait is abnormal. That's gait is known as a waddling type of the gait, broad-based gait, waddling gait, and it occurs in the congenital dislocation of the hip, or displaced and of the hip, any hip problem having this gait, this is known as a waddling gait, in developmental dysplasia of the hip. So if we look at the radiology, this is the acetabulum, this is the head of the femur, which lies inside this cavity in the acetabulum. Okay? This is the femoral head, and this is a normal hip joint. Okay, and if you look in the femoral head, it turns outwards. This is dislocated. It is not approximate inside this area is acetabulum, and it is outside from the acetabulum. Okay, so look at this. There is the difference in between these two. This is a dislocated hip. This is a normal hip joint. Okay. So this is the anterior posterior view. So look at the both pelvic bones. Look at the hip joints. This is a normal hip joint, and this is a dislocated hip joint. So after diagnosis, how you will treat this condition? The treatment of developmental dysplasia of hip should be individualized and depends on the patient's age and whether hip is subluxated or dislocated. At birth, when an unstable hip is recognized at birth, the maintenance of hip in the position of flexion and abduction, the human position for at least for 1 to 2 months is usually sufficient. And this position maintains a reduction of the femoral head and allow for tightening of the ligamentous structure as well as the stimulation of the normal growth and development. Methods that can be used to maintain the hip and this position include the pelvic harness. The pelvic harness is important, a split to use for the stabilization of the hip in normal position and the variety of abduction orthosis. Sometimes people can use the double and triple diapers, although controversial, and commonly used in newborn with dislocatable hips for at least 2 to 3 weeks because the splints and the harnesses usually do not initially fit satisfactorily. Treatment is continued until there is a clinical stability of the hip and ultrasonographic or radiologic measurement are then normal. So at the age of 1 to 6 months, during this age, a true dislocation may develop. As a consequence, treatment is directed towards a reduction of the femoral head into the acetabulum. The pelvic harness is the treatment of choice. In this age group, the harness attempts to place the hip in the human position by flexing them more than 90 degrees. So it means that hip should be flexed more than 90 degrees at around approximately 100 to 110, we can say. And it is gently abducted. If you assume like a frog-like positions, then abduction it up to 50 to 70 degree, and it is supported by the pelvic harnesses. It has certain braces. It should hold hip in a normal position in which the head of femur kept inside the acetabulum is to stabilize the hip joint. This redirects the femoral head towards the acetabulum. Usually spontaneous relocation of the femoral head occurs within 3 to 4 weeks. The pelvic harness is approximately 95% successful in dysplastic and or subluxated hip joints, and 80% successful in the true dislocation. If reduction is achieved, use of harness is continued until radiographic parameters have returned to the normal. If a spontaneous reduction does not occur, a surgical close reduction is indicated. So when there is failure of this pelvic harness is almost, it has a successful rate over than 90% or 95%. But if it fails, then surgical closure reduction is indicated. And from age 6 months up to 18 months, in older infant, the surgical close reduction is the major method of treatment. If at the time of reduction there is a significant instability, and open reduction may be indicated. So it is my message is to recognize early and intervene early the result and outcome is good and no need of open reduction or any surgery. If you diagnose later on of any failure of this spread methods, then there is a chance for the open reduction. And if age is even more than 1.5 years, up to 8 years, and after 18 months of the age, the progressive deformities are so severe that open reduction followed by pelvic osteotomy. Osteotomy or femoral osteotomy are both is necessary to realign the hip. So later on, the procedure may become complicated. So what are the complications if we don't treat the developmental dysplasia of the hip? The most important severe complication of the development dysplasia of hip is avascular necrosis of the capital femoral epiphysis. Other potential complication in DDH includes the redislocation, the residual subluxation, the acetabular dysplasia, and post-operative complications such as wound infections. These are the complications can occur in the patient. So thank you very much for your kind concentrations and listening this important topic. So my message for the is that you should perform the Ottolini and Barlow maneuver. And if you have doubt that there is a dislocatable or hip is already dislocated, then you can intervene early to avoid the late complication or any surgical needs, okay, in the hip. For the checklist, you should do the complete thorough examination from head to toe, front to back. You found any abnormality, even the color changes, the cyanosis, the plethora, any abnormality in the eye, scale, ears, okay. So newborns, 3 parameters important. You do the anthropometry, the length, the weight, FOC is important. Then thorough examination, genital examination is also important for the description of the gender. And you can do the back examination for any missing things, like you may miss any imperforated anus or meningomyelocele. So the back examination is also important. So make a routine top to toe examination and front to back examination. Okay, thank you very much for your kind listening. If you have any query, any question, you can email me. I will reply it. If you have any question, you can ask right now. Okay, so thank you very much for your kind listening. Thanks all.